Department of Surgical Gastroenterology, what we call previously, and now, you name it, hepatobiliary and pancreatic surgery. And we have two interesting talks on, one talk is going to be on shunt operations in portal hypertension, and another is the high-profile liver resection. And the first talk is going to be from Dr. Jayapal, the shunt operations for portal hypertension. I was fortunate to see his surgeries very recently. After seeing his surgery, I was very impressed. I should have become a surgeon. And he is very energetic now, after receiving his much-awaited convocation very recently at Delhi. Over to you, sir, to deliberate on shunt operations on portal hypertension and its current status as far as the management of the portal hypertension is concerned, with reference to the current evidences in the management of CLD. Over to you.
Good morning, everyone. I would like to thank our management for providing this platform consistently to share, learn, and exchange our knowledges. My talk will be on shunt surgery for portal hypertension. It's relevant in the current period. Portal hypertension is defined as the portal pressure measuring over 10 millimeters of mercury measured directly on the portal vein, and based on the anatomical resistance to the portal flow, it's classified into pre-sinusoidal, sinusoidal, and post-sinusoidal touch. This talk will be solely focusing on the pre-sinusoidal type of portal hypertension with EHPO as the primary concern. The examples for sinusoidal types will be in all types of cirrhosis because of alcohol and biliary types, and Budd-Chiari syndrome is a classical example of post-sinusoidal portal hypertension. So this picture depicts the pre-sinusoidal type of portal hypertension, where, as the name indicates, in extrahepatic portal venous obstruction, also called as EHPO, the resistance to the portal flow rise in the extrahepatic part of the portal vein. So thereby, the increased portal pressures will be seen in the SMV and splenic vein territory, causing esophageal and gastric varices predominantly. In the non-cirrhotic portal fibrosis, the resistance lies in the intrahepatic part, but on the pre-sinusoidal side. So coming to the topic proper, EHPO, called as extrahepatic portal venous obstruction, etiology remains largely obscure, and it's mostly attributed to the neonatal sepsis. It accounts for around 1/3 of the acute varicose bleeding presenting to emergency services in our country. The usual age of onset is in the young people, and the presentation usually is within 20 years and mostly before puberty. In contrast to the cirrhosis patients, these patients have a normal liver with normal liver functions, and so even if they bleed, they can tolerate it well. In that, cirrhosis patients after a bleed will decompensate eventually, whereas in EHPO, even after bleeding, they can compensate it well. But the magnitude of bleeding can be very severe to the extent that bleeding itself can kill this patient. So bleeding is the killer in these patients. Apart from the bleeding, other issues can arise in the form of growth retardation in children. There can be portal biliopathy, splenomegaly, and symptomatic hypersplenisms. So in the surgical management of EHPOs with portal hypertensive bleeds, various options are available. Proximal splenorenal shunt is the most commonly performed shunt operation because of reasons like massive splenomegaly and hypersplenism. In proximal splenorenal shunt, splenectomy is done, and the proximal splenic vein is anastomosed to the left renal vein. This is the most commonly performed operation. It's a non-selective shunt in that it decompresses the entire portal system into the systemic circulation. The distal splenorenal shunt, also called as the Warren shunt, is a selective type of shunt, wherein only a splenic vein territory of the portal hypertension part is decompressed. Here the spleen is left in situ, it's not removed, so that the splenic vein decompresses the spleen and the splenic vein side of portal hypertension. Mesocaval shunt is largely not done nowadays because of the poor results. Reg shunt is a more physiological shunt, but the only issue is anatomy in most of these patients. Say in 90% of these patients, anatomy will not be favorable to perform a reg shunt. In reg shunt, like in CABGs, coronary artery bypass grafts, the block is bypassed with a graft from the superior mesenteric vein to the left portal vein. The problem lies here, in which the left portal vein will be mostly atretic or narrowed, and it will not allow a safe landing. So we'll be discussing about the steps of proximal splenorenal shunt, which is the most commonly performed shunt operation for EHPO. So we place a L-shaped incision to open the abdomen, and opening can usually encounter a massive splenomegaly. And after which the lesser sac is opened with careful ligation of many collaterals lying in the lesser sac. And at the superior border of pancreas, splenic artery is mobilized and ligated in continuity. This will be the first step, and on ligation of the splenic artery, spleen size will get decreased. And after that, splenic hilar dissection is initiated, and splenic hilum along with the splenic vessels will be isolated and ligated. The spleen will be detached from its attachment to the retroperitoneum, colon and kidneys, and the splenectomy is completed. After splenectomy is completed, the splenic vein is mobilized to an adequate length where it can be brought to the renal vein for anastomosis. So this is a picture showing left renal vein which is mobilized and looped for a safe anastomosis. And this is just before the anastomosis where the splenic vein is mobilized and kept ready to anastomose to the renal vein. So in preparation, a side biting clamp, also called as a Satinsky partial clamp, will be applied over the renal vein, and an end to side splenic vein to renal vein anastomosis will be performed. So this video will show this is the left renal vein, and here lies the splenic vein. And once the splenic vein is adequately mobilized for a tension-free anastomosis, a clamp, which is a Satinsky clamp, will be applied partially over the left renal vein. Left renal vein will be opened adequately to the diameter of splenic vein, and then an end-to-side continuous anastomosis will be performed. So this is the diagrammatic representation of a shunt, and this is how a shunt will look like at the end of completing the procedure. And this video again will show the completed shunt where the splenic vein is anastomosed to the renal vein and is sitting nicely without any tension. So the results of the shunt operations are very good in tertiary center like ours, in that it controls bleeding effectively. The rebleed rates over a long run period, even in a 20-year follow-up period, is less than 5%. Apart from controlling the bleeding effectively, it also ameliorates the symptoms related to hypersplenism and splenomegaly. It reverses portal biliopathy in main say in up to 75% people, and it also improves the growth in children who usually have growth retardation with these issues. Complications are very few and rare in experienced hands. Mortality is almost nil nowadays. Shunt thrombosis is even meager with only 5 to 7% incidence in the long run period. Hepatic encephalopathies are rare because they have a very good liver with normal functions. And OPSI, their incidence has largely reduced due to immunization schedules. So before the further discussion, I would like to introduce to 3 cases which we saw, and 3 cases are all different in their presentation and spectrum, and the follow-up of these cases I'll be discussing at the end of this presentation. The case 1 is a 48-year-old male patient who had recurrent bleed for portal hypertension due to EHPO. Multiple endoscopic interventions was done in him elsewhere, and he also developed portal biliopathy in the due time, and he was ERCP stented for portal biliopathy as well. In the case 2, we had a 27-year-old male who had 1 episode of bleeding for which endoscopic band ligation was done, and then he was referred to us. The case 3 is a 48-year-old male who was evaluated for a pain abdomen and diagnosed with EHPO. He had no bleeding prior. On endoscopy, he had high-grade varices and he had no portal biliopathy. I would like to discuss the advantages of PSRS over endoscopy, because endoscopy lies the initial management option or the most widely available management option for portal hypertension bleeds. But specifically discussing about EHPO, shunt operations have multiple advantages over endoscopy. In that, shunt operation offers an one-time solution to the bleeding issues. Lifelong follow-up is not required as in endoscopy, where patients are called periodically, say yearly, to have a check endoscopy and band ligation whenever required. If you are ligating or band ligating an endoscopic esophageal varices, the root cause is not addressed. The portal hypertension part is not addressed. So these patients will eventually develop varices elsewhere. If you obliterate the esophageal varices, they will have fundal varices and they will have portal hypertensive gastropathy, which are difficult conditions to treat. When these fundal varices are treated with glue injections, they can have portal phlebitis and splenic vein phlebitis, which will lead to splenic vein thrombosis and portal thrombosis. And these patients, unfortunately, will miss the window to perform a safe shunt operation. and it will not address endoscopic interventions, will not address painful splenomegaly and hypersplenism. It only obliterates the varices and its concerned bleeding. And portal biliopathy is a problem with long-term endoscopies because, see, this picture shows the pathogenesis of portal biliopathy. Since the portal vein is blocked in its extrahepatic part, there will be multiple collaterals in the periportal region. These collaterals will get enlarged due to repeated endoscopic interventions and then can compress on the bile duct, thereby causing a compressive effect on the bile duct with stricture over a long run and obstructive jaundice. So, why am I even discussing the advantages of PSRS over an endoscopy? Because it's not a debate versus in the shunt versus endoscopic surgery. Because endoscopy is an easily and an attractive option for these patients. It's readily available. It can be offered in even in any small setups. Learning curve of doing an endoscopy is shorter as compared to the learning curve of performing a safe shunt operation. And the training to do a shunt operation with the training centers doing the shunt operation routinely is also very few now. But I'd also like to reiterate the fact that endoscopy has a significant role, only that patients has to be prioritized before finalizing on the particular treatment modality. Endoscopy is the modality of choice for acute variceal bleeding. It controls the bleeding effectively in emergency situation. It has a role in primary prophylaxis. In patients without high-grade varices, endoscopic follow-up is still the preferred modality of choice. In the outset, it's a teamwork effectively. And our patients are very fortunate to have a team like us where we and MG team work in close association and patients are prioritized over any particular procedure. So, but why does this topic of PSRS and shunt operations even need to be discussed? Because the incidence is low and the centers performing shunt operations are very few. And we can proudly say we are one of the centers performing good number of shunt operations. And we have trained surgeons in our team, and throughout the state, if you count, it will be in single digits where a safe shunt operation can be performed. And also, these patients, most of these patients are in low socioeconomic status, and since it's an one-time solution and patients can be put to their daily livelihood with a single surgery, we support and do these operations under same scheme. So, I would like to finish this case follow-ups. The first case where multiple endoscopic interventions are required, we feel that the patient was referred late from elsewhere to our surgical treatment, and this patient had a very difficult surgery requiring 9 hours of operative time and 5 units of blood transfusion. And in the due course, he was shifted to ICU but recovered well later and he was discharged on postoperative day 12. Whereas in the second case, where the patient was treated with a single endoscopic intervention and then was referred to our care from our MG team, the surgery was very straightforward. He did not require a blood transfusion. Patient was discharged on post-op day 5 and he is doing well. In the third case, who happens to be from my native, he initially came to us and then since did not have a bleed and only one endoscopic intervention was required with no recurrence of high-grade varices. He is asymptomatic now. He has been with the MG team with the early follow-up. So endoscopy and surgery should go hand in hand, and patients has to be individualized and selected for a particular procedure. We have done around 15 patients in the last 5 years. We can take around 2 years of COVID time, and all these patients are doing very well with no rebleeds. They are not advised a routine follow-up. They come for other illnesses since it's a practice of meeting a surgeon after a surgery for any ailments. So we get to know their results, and all these patients have very good and long-term and short-term outcomes. So I can summarize saying shunt operations effectively control variceal bleeding and it's only keystone for survival in patients of VHPO. Surgery offers an on-time treatment, which is the crux of this presentation, and a single procedure can tackle multiple problems like splenomegaly, hypersplenism and portal biliopathy. And the need for giving this talk lies in the fact that my alma mater AIIMS New Delhi has a very vast experience in shunt operations and they have performed over 1,500 shunt operations. Yearly there will be around 100 operations of shunt procedures. So the journey of shunt operation went from some 15 years back. There were multiple publications. In one publication, we suggested that surgery can be recommended as a primary prophylaxis for the shunt patients. And it has come a long way from suggesting surgery as a primary prophylaxis to the point where my HOD is writing an editorial asking a question, is the knife irrelevant in EHPO? I would conclude saying this knife is still relevant, is very much relevant. and only that people has to be aware of the advantages of both the procedures. And I would like to thank our management, and in no particular order, our anesthesia team, intervention team, our allied specialists, our senior surgeons, our nursing team, and the ICU team, as well as intervention radiologists, for help us in performing all these difficult operations. And thank you. I would like to take any questions if you.
Thank you, sir. That was a very nice talk. And I'm sure these surgeries were very familiar decades before. So obviously, you might take questions.
Thanks, Dr. Jaipal, for excellent talk, and I congratulate your team for doing this work. We were doing this days when we didn't have ultrasounds, when we didn't have imaging modalities. So only thing was any patient coming with upper GI bleed, we used to think of doing a gastric devascularization as well as shunt surgery. But the results were really poor. Maybe 1 or 2 survived, we lost many patients in those days. Many units of blood used to be given, we used to take them to the post-operative ward, and we used to lose some of them. So it was so difficult those days. Then came the ultrasound, endoscopy. When endoscopy came in, they said there's no role for shunt surgeries because endoscopists took over, and then we also started doing banding. Before banding, we used to do glue injections. So we were happy that we were able to control the bleeds and many patients survived. But as you said, they have to come for periodic follow-up, and repeated injections were given, repeated bandings were done, and we used to pull along like that. And now I think you're all well versed and well trained in this. So shunt surgery is again coming up, and probably with improved techniques, imaging, etc., it's becoming very good. And I really congratulate you all for this.
Thank you.
What is the role of TIPS? I think TIPS is also being done. Dr. Muthraj here?
Yeah. So since this topic was solely focused on EHPO, I didn't discuss about the tips. Tips in suitable patients, we are doing, Dr. Muthrajan is doing a fantastic job. In cirrhosis who are compensated or who are decompensation in the form of ascites but are suitable for tips, like portal vein is patent, if creatinine is normal and bilirubin is not beyond 3, all these patients are suggested tips as a long-term option, and in patients waiting for transplant, it's suggested as a bridge to transplant. It can increase their quality of life and decrease ascites in the waiting period. And for Budd-Chiari syndrome with suitable anatomy, tips is being done.
Regarding the diameter of the splenic vein, is it any criteria to say that these patients are suitable for shunts?
So we have done shunts ranging from 5 millimeter of splenic vein to 15 millimeters. If larger the splenic vein will reduce the size of the shunt, but smaller veins are not an issue. Only that anticoagulation is required for long term and smaller patients, smaller shunt size patients.
So the teaching was less than 1 centimeter, they are not suitable for shunts, and it's like that.
So like in portal vein, the flow is the predominant factor. Since these patients have portal hypertension, flow is very good, and then even a small size of shunt will not block because of the flow. If the flow is poor, even if the adequate size, then shunt thrombosis is an issue.
That's what. So nowadays you are able to measure the flow, the pressure, etc.
Yes,
in those days we used to do a spinoportovenogram. It's really a risky procedure, and we used to prepare the theatre ready in case if it starts bleeding, we have to go for an emergency splenectomy also. We used to put a needle into the spleen to strike one of the sinusoids and inject a dye, take and see the diameter of the portal vein as well as the splenic vein, and then plan for shunt surgeries. But the scenario has totally changed now, and once again I congratulate you all. Thank you.
Yes. Thank you.
I think, so I have a question to you. So this EHPO, you can have a reversible, you can have a causes for that. Like for example, prothrombogenic state. I have a hypothetical question, or it can be practical question. You have an EHPO, for example, essential thrombocytosis. You do a surgery, and if the patient develops again thrombosis in the anastomotic segment, what will you do that for that?
Sir,
or you evaluate all this. There are 4 or 5 T's like that, I think. Essential thrombocytosis and myeloproliferative disorders. There are so many prothrombogenic states are there. So you evaluate all these patients for prothrombogenic state and you do surgery. One. Number 2, if there is a reversible cause, is that candidate for surgery. Number 3, what is the recurrence of the primary problem? For example, primary coagulopathy, the primary hypercoagulable state causing an EHPO, and undergoing surgery later on recurrence in that anastomotic segment.
Okay, so
I think question is relevant.
yeah, yes. With the available evidence, Indian patients do not have a procoagulant state as the cause of EHPO, whereas in Western patients, procoagulant state is a significant issue. In a study of patients compromising of 6,000 patients, which is a multi-center study between AIMS, ILBS, SGPJ, and GP Pant, only 1% was found to be procoagulants, and all these patients were over 40 years of age. So in young age people, procoagulant state workup was largely negative. And second, if we do a procoagulant workup and something turns out to be positive, which in most cases usually is protein C, protein S, and factor V leading mutation, these patients will be kept on lifelong anticoagulation.
In addition to surgery.
In addition to surgery. And as far as the primary issue is concerned, only anticoagulation is not going to resolve the portal vein thrombosis.
Yes, we had a recently patient with this factor V leading mutation, protein C, protein S, but that is not EHPO, that was Budgie.
If it's a secondary portal vein thrombosis, then in that case surgery is not offered. EHPO is a primary portal vein thrombosis.
The study which you are quoting, largest series, what is the number? I'm sure one of the cause for, I think, cirrhosis would be an EHPO leading to portal biliopathy, later on liver disease.
Yeah, yes, sir.
Sir, I think gastro can correct if I am wrong in these concepts. So, if that is so, what is the number of patients of EHPO undergoing surgery later on developing chronic liver disease after surgery?
So, in EHPO, the patient is undergoing surgery. Usually, they will not progress to liver cirrhosis.
But that was untreated EHPO, what I am quoting.
In untreated EHPO, with the patient develops portal biliopathy and a secondary biliary cirrhosis, then transplant is the only option.
That time you don't take these patients for surgery. You have a mic.
Just adding comment, it's not a question. Actually, most of the time, what we see is a patient comes to the emergency with a torrential GI bleed. So, I think we remember Murugesh sir, one patient came with a torrential GI bleed, was admitted in ICU. When the endoscopy was done, the collaterals, the varices almost like an IBC. Was so much of big, it will not be able to intervene with the endoscopy at all. So what he did, he put the sensation tube and control the beat and keep it in the ICU. By the time we prepared the patient for surgery, most of the sitting, the emergency, that's where the surgical comes into that scenario. Then later on, patient came very early and follow-up. So the surgery becomes an elective thing. So initially it was an emergency sitting. It's very difficult to control the bleed. I think MG people will know that. So that's the main indication for surgery most of the time. Thank you.
Sir, considering the etiology is concerned, most of the times the disease is diagnosed at the younger age, like in the age onset at the 10 years or 11 years. And most of the times they have got a repeated childhood infections. That is the first predisposing factor for the EHPO. Not as Jaipal said, it's not like most of the times it's not.
Usually
like
in those days where the good perinatal hygiene is not practiced, umbilical sepsis is one of the cause.
That is still it is the main reason for the EHPO. And also, as Dr. Keswan sir is saying that mainly the sun surgery should be encouraged for the patients who are not getting the access to the medical care immediately, because if they develop a massive GI bleed, then the risk for life is more. So the patients who can't afford the medical care at the earliest time, so they should be encouraged for sun surgery at the earliest time.
Okay. This topic was my first presentation as a medico.
Yes. It's as Sabari sir said, it's a indication which is given in the books where patients who do not have access to the healthcare and who have rare blood groups should be offered sun surgery earliest.
Okay. So what's your take on is knife and stethoscope are hand in hand or complementary or pro-con debate?
It's hand in hand, sir.
Thank you.
Thank
you for your wonderful presentation. Over to Dr. Prakash to deliberate on vascular reconstruction and liver resections.
Good morning to one and all, and thank you very much for your valuable time this morning. So, human being has always been pushing the limits of whatever they do, and that's how progresses happen. So, in right from each and every invention or each and every development that has come, we are trying to push the limits that we had reached before. So, today my presentation would be the extending the limits of the liver resections in liver cancer and what we have been doing, and I'll be giving a glimpse of the cases that we have done recently. So, to understand first the liver resection.
Sorry, so we have just modified the topic after the circular has sent, so please bear with us.
Okay, thank you. So, what forms the basis of this liver resections? I think there are so many junior doctors and nurses as well, so they understand why and how is this liver resection possible. Being a single organ, how is this even after you resect the liver, how the patient is able to cope up with it. So that we go back to the anatomy. A liver usually is divided into 8 segments. This forms the basis of our liver resections, because each and every unit here, they can function as a single unit as such. So this forms the basis, so that once we remove a segment of the liver, the other units still overtake the functions of the rest of the liver, and it's able to sustain the life in that patient. So here it's divided into 8 segments, and you can see on the left hand picture, so that is the red line that divides into the right lobe and the left lobe, and further they again divided into various sectors. So totally we have 8, and some says there's also 9 segments including the caudate process. So next, with these 8 segments we know that. So next, depending upon where this lesion is or where the tumor is situated, we plan our resections. For example, we do a right hepatectomy for a tumor occupying in the 5, 6, 7, 8, or a left. And if a tumor is situated somewhere in between, if it's involving between, for example, if it's somewhere between 4 and 5, we go for the extended right hepatectomy, or in a similar way, if it's on the other side, we go for the left extended as well. So we are actually in these surgeries, we are removing a very significant amount of liver tissue, and the amount of liver which we are going to leave behind should be able to sustain the patient's life. So what are the most common tumors we encounter? There are numerous, but I'll just speak about just 4 of them which we encounter, very common. So HCC forms 80% of the patients who undergo liver resections, and next is the cholangiocarcinomas, and next the secondary liver, the metastasis colorectal liver mets form the most common, and we also see secondaries from the other neuroendocrine tumors as well, and a primary neuroendocrine tumor in the liver as well. So what are the factors? So when the patient comes to an OPD or in the ward, we diagnose the patient, okay, this patient has a liver lesion or a liver tumor, whatever sort. So what are the things that goes through our minds? So first is the nature. What is the tumor biology? So whether it's a HCC or whether it's a cholangio or it's a secondaries, or next whether it's a neuroendocrine tumor, because each and everything they have their own different prognosis, and the treatment should be monitored, should be tailored to the same. And next is the extent of the disease. And for example, I would say, like, if there can be a single lesion in a very, for example, if you take up this picture, if there is only one tumor somewhere in the segment 6 or segment 5, if you remove just that one lobe, that will be enough. But if the same lesion is somewhere in between, we need to remove more segments. So that's why we need to know how much is the tumor, what is the size of the tumor, and what is the extent. There can be, at the same time, there can be 2 or 3 lesions in the same lobe, or 2 or 3 lesions each in a different lobe. So these all we need to take into consideration before planning for the resection. The next is the quality of the liver, and this is much more important in the present day scenario on the type of food we eat and the lifestyle changes. And how much is the fatty component of the liver? Many times we do ultrasound, it comes as fatty liver. And how good the quality of the liver, because once you resect the liver, how the rest of the liver, whether it will be able to sustain the patient. So that is also very important. And the next thing is the vascular involvement. These tumors, particularly the lesions that are located in the hilum, they very easily infiltrate or engulf the portal vein or hepatic arteries, and these in turn determine whether a resection will be possible, it's inoperable, or how easy this resection is going to be, or how difficult this resection is going to be. And next, much more very important thing is the future liver remnant. That is, after you remove the liver, the rest of the liver, whether that will be enough for the patient. See, this actually how surgery is going to be important. The 50% goes in the pre-operative planning. In this, the future liver remnant forms the most important part. Because obviously in case of extended resections, we remove almost 6 segments of the liver. The patient will be just left with the remnant 2 segments, and whether that will be enough for the patient. So whether we had, or pre-operatively you try to find out, this patient might end up having a liver failure after the surgery, you do something before so that you increase the size of the liver. So next is the patient general condition. This forms the most important part. There is no point in operating a patient with a poor general condition, even though the lesion is inoperable. So how we make this liver resections a much safer one? So preoperatively, if the patient has a jaundice, obviously the liver is dysfunctional, you try to drain. Many times you do a PTBD, or sometimes you do ERCP as well. And cholangitis, a patient with the cholangitis with an infection, obviously the patient's complication rates are much higher in the post-operative period. You drain the biliary system. And the next is for need for preoperative liver augment. Try to improve the size of the liver preoperatively, so that post-operatively the liver is much enough for the patient. So there we have portal vein embolization, and sometimes stays to some extent. And next, vascular involvement. This vascular involvement many years back, it was deemed as to be inoperable, unresectable, and the patient was left just for palliative care. But as techniques evolved, now we are able to resect and reconstruct the hepatic artery or portal vein, which in turn gives the patient a complete cancer clearance. And also the next thing is the liver volume loss. We are able to now modify our resection so that to preserve another 100 grams of liver, another 200 grams of liver, which will be much more valuable to the patient. And next is a complex biliary reconstruction. Obviously, bile production is the important part of the liver. And post-resection, patients developing bile leaks, or if a segment of the liver is not drained, that leads to the atrophy of the liver which we gonna live. And this in turn again results in complications. So we are able to do an biliary reconstruction in these things. And now I'll be just placing my importance on 2 things today. That is, one, increasing the future limit, and next is the vascular resections. So for this, first I'll discuss a case. A 49-year-old gentleman who presented with a back pain, and he was evaluated outside, and he was found to have a large heteroic lesion in the segments 7 and 8 of the liver. It was a normal liver function, but he was obese. He was weighing 101 kgs, and the lesion was between the right hepatic vein and the middle hepatic vein. It's a large lesion. I'll show you the CT next. So this patient, we calculated with the CT, we sat with the radiologist, we calculated, okay, how much of the liver will this patient have once the resection is complete. So that came as that FLR means future liver remnant. That is, how much of liver will the patient have. So it was about 450 grams. With a patient of 101 kgs, that forms less than point. The ratio of the liver to the body weight is less than 0.5%. Obviously, this patient has an 80% chance of developing a complete liver failure in the post-operative period. That leads to a very high mortality. Obviously, this patient would be unsuitable for a liver resection at this point of time. So what next? He's 49, he's young age. So we try to do something so that, is there something we can try to do so that to increase the liver volume? So there comes, so before that, this is the scan of this is the CECT showing a large lesion, the segment 7 and 8 of the liver. The right hepatic vein is completely engulfed, the middle hepatic vein is almost narrowed. So before going to that, so in this patient, so increase the size of the liver, we plan two things. One is the portal vein embolization, and another thing is an transarterial chemoembolization. So, as you all know, liver receives 80% of the blood supply from the portal vein and just 20% from the hepatic artery, which is much different from compared to the other organs. But a tumor receives most of blood supply from the hepatic artery. So what we did is that before going for because once you embolize the portal vein, the tumor will start taking the blood from the hepatic artery and it will be happily growing there. So what we did is that we blocked the hepatic artery first, waited for 3 weeks, and then again we went again with the portal vein embolization. So what is the portal vein embolization? That is, you block the blood supply to that part of the liver, that's it. So what does this do? So usually a part, for example, any other part of the body, if the blood supply is lost, actually that part going for gangrene, ischemic necrosis, forms an abscess and everything. But in case of this portal vein embolization, which is a much more calculated procedure, here the tissues, they don't go for much of an ischemic. There is a component that goes for ischemic, but it's much less. Mostly it goes for apoptosis. And the cytokines are being released, which in turn stimulates the growth of the rest of the liver. And liver is a much tolerant organ, and this has the organ which has a regenerative capacity. So this forms the principle of why do we do this. So in this patient underwent TACE, and after 3 weeks patient underwent a right portal vein embolization, and after the portal embolization we again repeated a CT which showed that the FLR, which we told us previously was just 435, now it has improved to 623. It might be just a mere 200 grams, but that is very much significant to the patient, and the FLR ratio was adequate now. So this patient underwent a right hepatectomy with excision of middle hepatic vein, and it's almost a year now, and the patient is doing well. So this is what we do. So actually we gain access through the other side, and this is the liver that will grow, and after that we resect the part of the liver with the tumor. So this is the IR image showing these are the glucas. This is the right portal vein which has been embolized, and this is the left portal vein, and this will be the main portal vein. And this is another IR image showing the same. So this is the comparison picture between the pre and the post embolization picture. So this is, you can see the left lobe has increased in size compared to the previous one. So this is how we do. So this is the parenchymal transection which we do. So this is a Kelly Kleisis technique. We use Kiza as well, as and when needed. We ligate all the portal pedicles that come in between, and we take care of, because there will be large vascular structures will be coming in between. We need to preserve them as well, so that the other segments, they don't become ischemic, the segment which are going to be leaving behind. So this is the left lobe of the liver, and down that is the IVC. You can see a pulsating structure down there, actually which is not pulsating, it's just a transmitted pulsation there. That's the IVC there. So now we can see it much clear. Here we go. So that's the IVC and the rest of the liver that's left behind. So next, we have case 2. This was a 34-year-old gentleman. See, you can see the age group now. We are seeing malignancies in age group. This is a 34-year-old, well fit, who just was evaluated for jaundice, and there's no comorbidities. On evaluation, is found to have a large lesion in the hepatic hilum with extension into the bile ducts. So to give a hint about this, this was an hilar cholangiocarcinoma. Hilar cholangiocarcinoma, how is it different and why is it so important is that these are very small tumors, but these small tumors are just at the gateway to the liver. They are just located at the hilum. So even though they are small, they can easily infiltrate the main blood vessels of the portal vein and the hepatic artery as well, and very easily they become unresectable as well. So this 34-year-old guy, so he was diagnosed to have this hilar cholangiocarcinoma. So he has obstructive jaundice with the bilirubin of 10. So what we need to do now? So going back to the previous thing, patient has an obstructive jaundice. So first we need to drain his biliary system. So what we did, we drained his, we put a PTBD and drain his bile. And next, we did a portal vein embolization as well, because his FLR was also much low, because this patient needed a right extended hepatectomy. And a CT scan after 4 weeks that improved. The FLR ratio was less than 0.5, now improved to 0.8%. So this patient underwent a modified right extended hepatectomy, and then after 5 weeks. So this is the pre and the post embolization picture. You can see the size of the left lobe here. There's a gross difference there. So this is how it looked in the resection on the table. You can see there's a line there. You can see the line. This is the side of the liver, that is the portal vein embolization. Okay, and this is how we are going. This is the liver that we are going to leave behind. And this is before proceeding with the resection. We all dissect and define each and every structure, the hepatic artery and portal vein. And that's the gallbladder, and this is the hepatic artery. And posteriorly we have the portal vein there. So in both these patients, with help of portal vein embolization, what we were able to achieve the required FLR, that is future liver remnant, and these patients were able to undergo a liver resection, which was previously not possible. So next, this is in regards to the portal vein embolization, and next is the vascular reconstruction. This comes hand in tumors involving the portal vein or the hepatic artery, and also tumors located at the hilum. So we have a case 3 to discuss on it. It's a 57-year-old gentleman evaluated for jaundice. He was diagnosed to have hilar cholangiocarcinoma. Part of the tumor, this patient was planned for a left hepatectomy, so obviously the left portal vein go away, but part of the tumor was infiltrating the right portal vein as well. So this is the picture there, and this is the tumor down there. Here you can see this is the tumor. We had divided the bile duct, we had lifted it off. Here it's attached. I'm able to see it here properly. I'm not sure whether you'll be able to visualize it there. So here, this is the part of the tumor that's adherent to the right portal vein. So what we had to do is that take off the, anyway left portal vein we are going to divide the right portal vein as well, and then you remove the tumor and then join the right portal vein to the main portal vein stump. That's what we had done. So this is the after the resection, this part of the liver is being removed, and this is where the right branch of the portal vein is anastomosed to the main portal vein branch. This is the right hepatic artery there. So this is what we were able to do. See, these are the glimpse of the 3 cases which we had done recently, and obviously this is what we have at the present. Obviously, these tumors are much advanced tumors. Whether these resections have improved the overall survival, yes, in these patients, such patients with the vascular infiltration, or the patients a large tumor who had been previously deemed inoperable, and now these patients have been undergone surgery, and there is an increase in the overall survival of these patients. But obviously, these patients do have a tumor biology that has already infiltrated the blood vessels, and it's large in size. That might have an effect on the overall outcome as well. So obviously, so that's all I have for today. So basically, I thank all the other specialties, management, and the intensivists, nurses, radiologists, and all staff members without whom these resections are not possible, because every now and then we take advantage of them many times. So, thank you. Yeah.
Thank you, sir. Since I'm sure there will be many questions, before they ask, I'll start my quota. The FLR calculation, you take the actual body weight or ideal body weight? Because in the first case, if I presume that you have taken actual body weight, if it is an ideal body weight, FLR would have been higher. So what's your take on that?
So the main
because every calculation in medicine are based on lean body weight, not an actual body weight. Is it different here?
No, actually here for the calculation we take the actual body weight, sir. And in this patient was weighed 101 kgs. Obviously 101 kgs even after and doing portal vein embolization, that might not be. Here we asked the patient to be on dieting. This patient has reduced almost 10 kilos before, in a span of a month before we proceeded with the resection actually.
You don't do sleep studies in this patient?
No, we don't do sleep studies.
Okay. No, there are enough evidences that in those patients who have an OSA, I'm sure stop bank question is being routinely asked in patients who have an OSA phenotype. So perioperative mortality is a little higher. Okay. So next question is, what was the cause of back pain in the first patient?
Sorry, sir.
What was the cause of back pain in the first patient?
Probably
or was it an incidental liver cancer? Because that's how the patients from master checkup lands in.
No, this was referred because it was a large tumor. The size of the tumor was much large in the liver. So probably the liver has been expanding, and obviously most of the patients, these patients do develop they come back with an back pain as well. So there's no other reason for it. There's no meds.
Because statistically liver CA presenting with back pain little odd until unless you have meds there or any other reason.
Yeah, so the patient is 1 year on follow up.
So I was thinking, was it a master checkup referral?
Okay. But because this back pain had disappeared after the surgery for the patient. So that explains that.
Okay. So what is the shortest time at which the liver can increase its volume? So because in the first case I saw, the CT was taken on 5th of February 2022. The next CT wherein the left lobe expanded, increase in number, the increase in the size, it was I think 22nd February 2022. Looks very shorter period for the liver to expand, so that's why.
Okay. Usually we wait for 3 to 4 weeks, usually. It's usually 4 weeks.
It was less than 18 days. Within 18 days, I think liver volume has increased in the first case.
Actually 3 weeks, sir. We wait for 3 weeks at least. That's the thing.
Because by seeing the CT data, it looks enormous size in the liver. So that's
I think probably the cut sections, I think probably it should have been there.
Okay, so I'm sure there will be many questions from
I will answer that last question. We have seen the liver regeneration based on how much block was very effective, regeneration capacity, it's all different. We have seen a patient with double the volume in 1 week, 1 week after embolization. And we have seen the patient double the volume in 4 weeks. So it's all depends on the patient's factors.
Variability. I was just curious to see, within 3 weeks got, I think that Murugesh sir left, that Sabrina then left. Okay. So any more comments?
The liver volume. It's a surgical method to increase the liver volume, wherein we divide the liver surgically divide the liver and ligate the portal vein, and the liver volume increases in 5 days time to adequate size. Okay, and then the reoperation is 5 days later, where the actual liver which has to be removed is removed.
I think medical guest was not here. Dr. Muthraj, I think you're also meddling with these areas. So you. Whenever he does taste now, so we are getting called for the chemotherapeutic drugs entering into our territory. There are a few cases of chemotherapy drug-induced acute NSIP pattern. So what's the surgical anatomy behind this? Sometimes you do taste. So people coming to us with acute respiratory failure. So it was drug-induced acute non-specific interstitial pneumonia that gets resolved with steroids. And what is the vascular connection between these two?
Most of the patients will have arterioportal fistula. So those patients sometimes, normally in a large fistula, we will embolize with gel foam or PVA particles, then only we will embolize. But it's little bit fistula is then normally till that chemotherapeutic embolization can escape into the lung. Those patients only rarely will encounter the problem.
So via RARV and pulmonary artery it goes
right,
into that.
hepatic vein and it will go to the lung.
Okay.
It makes sense because majority of the time the dominant lesion is seen in the lower lobe only. So preferably, because it gets more blood. Okay.
Okay.
So any more questions? So there are no questions. We thank you for your wonderful presentation.
Okay.
And to both the presenters and to the department, as a whole. Sir, you have any comments? If there are none, we close today's academic meet. We will meet in the next meet. Thank you.
Thank you so much. Thank you. Thank you. Thank you.